Good morning, everyone, and welcome. I'm Cindy Friedman. I'm the Senate Chair of the Joint Committee on Healthcare Financing. On behalf of Chairwoman Benson and myself, I'd like to welcome you to the committee's 5th legislative hearing. Okay, I would now like to ask, that's what I'm doing, Senator Eldridge and I think Rep. Sabato and Rep. Garlick.
Good morning. Chairwoman Friedman, Chairwoman Benson, members of the Joint Committee on Healthcare Financing, thank you so much for taking us out of turn. We are here to stand in support for Senate 683, House 1194, an act establishing Medicare for all in Massachusetts. This is the earliest that the Joint Committee has held a hearing on making healthcare right in Massachusetts, so we want to express our deep appreciation to the chairs. The legislation I'm very proud to file with Representative Denise Garlick and Representative Lindsay Sabadosa. An act establishing Medicare for all in Massachusetts would declare that it is the policy of the Commonwealth to provide equitable access to quality, affordable health care services for all of its residents as a right, responsive to the needs of the Commonwealth and its residents without co-payments, co-insurance, or deductibles. The bill would create the Massachusetts Healthcare Trust, guaranteeing to pay for all medically appropriate health services, funding capital investments to make sure that every part of Massachusetts has adequate health care for its residents. It would include dental care, end-of-life care, and everything else we need to make sure that everyone has a dignified life from cradle to grave. If I were to compare it, Madam Chairwoman, to an issue to a value, I see it as public education. Is wherever you grow up in Massachusetts, you have a right to an education, you have a free education. We're really looking to make healthcare right along that same sort of model. How do we pay for it? Like any universal good, universal value, we would need to raise taxes to pay for it. It would include an employer payroll tax of 7.5%, exempting the first $30,000 of payroll per business, an additional 44% payroll tax on establishments with 100 or more employees, an employee payroll tax of 2.5%, a 10% payroll tax on the self-employed, and a 10% tax on unearned income. The bill would also include a workforce training fund, recognizing that more likely than not, health insurance companies would go away, and we would need to find a way to retrain those employees. So there's a national conversation on healthcare. We want to make sure there's a state conversation on healthcare. I want to offer a brief personal story, is that although I was always for single payer, making healthcare right, 10 years ago this fall, I suffered a major seizure. Was in both Mass General Hospital and Spalding Rehab for a total of 6 weeks. Had a major spinal cord injury as well as dislocated my shoulder. Beyond all the costs to be in the hospitals, it took me approximately 3 years to pay off those medical bills. I am very grateful to have quality health insurance like all legislators have. I'm very grateful to have a middle-class salary, but it took me 3 years to pay the medical bills, not only being in 2 separate hospitals for 6 weeks, but also all the rehab and seeing the specialists for a period of 2 years. So that really shows how broken this healthcare system is. And I would just conclude and say that if we're talking about the opioid crisis, single payer is the solution to addressing the opioid crisis. If you believe that abortion is a right, single payer health care is part of addressing the gaps in coverage for accessing reproductive rights. If you believe in mental health parity, single payer is the answer to mental health parity. If you believe that wherever you live, you should be able to access a doctor in your town, in the area, without paying any bills, getting quality health care, single payer is the only solution to that. This movement is growing across Massachusetts. Again, I want to thank the committee for having an early hearing, and really appreciate it for everyone who came in the auditorium. Thank you very much.
Good morning to the chair, people, and committee members. I'm Denise Garlick. I'm the representative from the 13th Norfolk District. I will be very brief out of the respect for the many residents of the Commonwealth who have traveled here to speak to this committee, but I pledge to you my assistance in any of the work that you are doing going forward. I want to wear, like many of you, I wear many hats. In this setting at this table today, the most important hat I wear is that of a direct care staff nurse for several decades. And I wanted to share with you my experience in witnessing the healthcare system. In the beginning of my experience, the healthcare pyramid to me had patients at the very top, and the foundation was the providers and the healthcare business, the way we did healthcare business. In that time, over the last several decades, I have witnessed a toppling of that pyramid, and now we see the healthcare business delivery system at the very top. It is pressuring the providers, regardless of their credentials or their titles, to be able to deliver the care that they know that individuals need, and it is crushing the needs of patients. This bill gives us a lens to address that healthcare business delivery system and ways that we could begin to address that. The second thing that I want to say is that any bill, just like any idea, can either be used as a tool or a weapon. It has been my hope in the years that I have spoken about a single payer system, regardless of what we call the title, now we call it Medicare for All, that it is a lens that we can address that healthcare delivery system. But we must be cognizant of the immense power of the federal government in this kind of system and how we would change that, as well as the pressures of the many stakeholders that are involved with vast amounts of money. We must be very careful that we use this bill as a tool to bring together like-minded individuals and not allow us to divide us. And in the Healthcare Financing Committee, it is not only this bill, but the hundreds of bills that you are looking at that I am hoping that this bill is helpful to provide a lens to address those needs. Thank you.
Good morning. Thank you to the chairwoman, and I am delighted to see two chairwomen, so it's refreshing. I also want to thank the committee members who are co-sponsors of this bill, so Chairwoman Benson, Representative Cullinane, Representative Ash, Representative Barber, Representative Lutrino, Representative Higgins, and Representative Santiago. Thank you for being co-sponsors. When I was a child, my family spent a lot of time trying to impart sage financial advice. Put 10% of what you earn in savings, never buy something new when you can buy it used, and buy the best health insurance you can afford. I never questioned that last statement. It just made sense. Everybody knows that without the best health insurance possible, you end up with medical debt. And who wants to end up with medical debt? I started my own business, and I did just that. I bought the best health insurance I could afford. I was a sole proprietor, and no one in my family ever seemed to get sick. So I bought a mid-range plan and thought nothing of it, except every year when the plan renewed, and it was either stay with the same premium, but with a higher deductible and a higher copay, or pay more for a premium. We were okay though, and I didn't spend a lot of time thinking about how really it's only in the United States where access to healthcare and healthcare coverage are directly tied to financial stability. Then, what happened to many families happened to ours. My partner got sick, very sick, with cancer. And right after the oncologist told us that he had probably about 27 small tumors in his lungs, she looked at me and said, "I'm really sorry, but we need to talk about health insurance." Because our health insurance wasn't going to cover continued treatment at that hospital. And so we left the emergency room that day knowing that it was probably cancer. We don't know what kind of cancer. We don't know where we're going from here, but please go home and find a hospital that will accept your health insurance. That day changed my life. I had been a proponent of single payer. I had been lucky enough to live in 4 different countries where there was single payer health care. And I hadn't put the pieces together, but I can tell you I put them together that day. The best health insurance that I've received has almost always been overseas, oddly. We talk about what a great health insurance system we have, but when I had near debilitating UTI, I was able to go to the urgent care center at Amsterdam Airport, get treatment, get diagnosed and treated so that I could get on a long-haul flight, and the doctor charged me 40 euros. Something here is broken. When I started to campaign, single payer was one of the key issues I talked about it. I talked about. And I talked about it every day to everybody I met, on every single door, and I knocked on a lot of doors. Some of the stories that people said, please share, were the story of a man whose heart stopped while he was at work, a single father on Mass Health. And his story is, thank God I had Mass Health, but I promise you I will never take on more hours because that would mean I couldn't stay on it. A woman who had polio as a child, and because one of her legs was impacted, her health insurance currently only covers varicose veins in one leg, but not the other. A mother whose son had a stroke, her adult son had a stroke. She had to retire early because her health insurance company said they would only pay for half of the physical therapy sessions the doctor was requiring. Those are just some of the stories from my district, and despite the rain and the horrible traffic, a lot of people from my district are here today, and they're going to share a lot more of those stories, and I'm proud to be here to represent them. Massachusetts can and we must lead in the fight for truly accessible, affordable, quality health care. Medicare for All is about health equity. You should not receive better care because you have more money. You should not receive better care or better access to care because of your zip code. And you should not have to make important life decisions based on whether you can afford health care. That's why I'm here today to start this conversation about how we move Massachusetts towards a single-payer system. Let's take all of the testimony we hear today, report this bill favorably out of committee, and then begin the work of making it as strong as possible so that we can finally have a healthcare system that benefits every single resident of the Commonwealth. Healthcare is a right. Let's send that message today. Thank you for your consideration.
Thank you very much. Is there any questions? Rep?
Thank you, Madam Chair, and thank you to my colleagues who testified today. I have a quick question on Senator Eldridge. You mentioned tax for this or a tax for that. Are there any studies or comparisons to say to employers, okay, there's a tax for this. However, if you look at what you're paying, I don't know, say you're paying 60 or 75% of your employee's contribution, or to the employee saying you're paying 20 or 25%, these taxes that we're imposing to pay for it is actually less than what you're paying or more than what you're paying?
Yes, President, thank you very much for the question. So there was the national healthcare study that was actually done by Perry, the economics department at UMass Amherst, and the national study said that, first of all, that a universal Medicare for all system is less expensive than the current system, including all the contributions of employers, employees, co-pays, deductibles, premiums. So this state bill, which is very similar to the federal legislation, is that, yeah, employers would no longer have to pay premiums, and the payroll tax they would pay would be less than the premiums that they're paying. And so it actually saved money for employers, as well as the point that many employers say, I don't want to have my HR person be involved in choosing 5 often not very good health insurance plans for my employees. I want to focus on my business and making it successful. And that separates the employer-employee relationship as far as health insurance and allows the business to just focus on the business and not providing health insurance.
Okay, thank you. And the other thing is we've heard testimony on legislation about nursing homes and such, to saying that the reimbursements for, say, Mass Health or what have you, crippling some nursing homes, causing them to shut down because we're not paying this, the percentage that private industry may be paying. Would you see that a problem if we went to a Medicare for all, that our reimbursements down the road may cripple those places from staying open? Or would you see us having to increase what we're paying to keep these places open? I have a lot of seniors in my district, and they're nervous, as well as there are many facilities that have been closing down because of the reimbursement rate. Would that still be a problem, or would we have to change that?
First of all, I want to allow my colleagues to speak as well, but I would just say that it's important to understand that Medicare for all term, it's a term of art. Mm-hmm. It's a term that, the vast majority of Americans support of Medicare. The legislation itself would make sure there's direct reimbursement for all types of healthcare services, including, in my view, for nursing homes. And so, this isn't the Mass Health for All bill,
Right.
where there's low reimbursement. This is the idea of reimbursement to make sure that hospitals are getting adequate reimbursement, nursing homes, doctors, medical professionals. And I do believe we can do that. And it's important to highlight that we did put in this bill, the taxes to pay for that.
Great. Thank you very much. Thank you, Madam Chair.
Chair Benson.
Thank you. Thank you. First, I want to formally apologize again for being late. A 2.5-hour drive is not typical if I leave after rush hour, but apparently there was no after rush hour today. But I wanted to state I am a co-sponsor. I am a big believer in single-payer health care. I have believed that my entire time in the legislature and before. I had in the past also filed my own bill, but chose not to this session to support these bills in theory. So what I want to get into, though, is when we move out of sort of the theoretical support of single payer and actual implementation, it becomes dicey. And I think that I wanted to hear from each of you sort of your thought process around this. So understanding that we don't govern Medicare and we have no similar system in Massachusetts. Even Mass Health is run, the plans are private insurance plans. So we have no experience doing this. And upon passage and signing of this legislation, 90 days, we would be switching to a single payer system. So my first question, and I'll kind of lay it all out there. So my first question is implementation. What is a realistic way of looking at implementation? Secondly, how long through this implementation would we need to have both systems running simultaneously? Because obviously we don't want anyone to go without coverage, and until we have this mechanism up and running, we can't force people off of their current insurance. So they would be paying both premiums and the new taxes to fund the system. So that's 2. 3, how would we address out-of-state employees, because they wouldn't be a Massachusetts resident and covered under this, but they would still be paying the payroll taxes if they're paying income taxes in Massachusetts. And so is there some sort of a waiver system that could potentially be included? I had one more question. I may come up with it, but let's start with that.
Mm-hmm. Well, I would just say is, one thing to reflect upon is that, in 1965, President Johnson signed Medicare legislation. So before that day, seniors had a variety of ways, often not very good ways, to get health care. Within a year, every single senior had Medicare. So, I do think that it's possible to expand health care access and make it a right in a similar way that happened with the federal Medicare legislation. In terms of how we would begin in Massachusetts, we would need to get a federal waiver from the federal government in order to implement single payer. The healthcare trust that would be created under the bill, federal monies would go to that trust as well as the revenues that we're proposing here. And we do believe that that's sufficient to provide health care to every single resident. As far as the transition, I'd be the first to acknowledge that it's probably a number of years transition, and I have confidence that the legislature, state government would be able to come up with a plan to make that transition. But it's really critical to emphasize that, with the revenue we believe we could raise from that payroll tax and taxing those who are wealthy, we would raise the money to fund that direct reimbursement. And I personally think it would be a fairly smooth transition for people to go from the health insurance they have to direct reimbursement, because while they would be paying the tax, they would fairly quickly no longer be paying premiums, no longer be paying co-pays, no longer be paying deductibles, and they would see the value of that very quickly. I don't know if my colleagues want to add to that.
Go first, Lindsay. So Representative Sabadoza has chosen not to answer this. I would like to answer this in the way that I have seen Massachusetts move forward. We are not at the beginning of this conversation. We are in the middle of the conversation. I was a member of the Mass Nurses Association who supported single payer in 1990, and we have begun those discussions. The Healthcare Financing Committee has been integral to the work that we have done. In the early 1990s, we were heavily dependent on the Department of Public Health around healthcare quality and their department and how we were evaluating what healthcare was doing. The work that Massachusetts has done, we all know that the pillars of healthcare are quality, access, and cost containment. We certainly moved forward very rapidly with access and brought so many people into the healthcare system. We have been struggling since that time around cost containment, and we have not yet addressed, in my opinion, in its entirety, the issue of quality. What I will say to you, however, though, through the work of the Healthcare Financing Committee, we addressed in Chapter 224 ways to move forward. This committee had helped to develop the entire concept of ACOs in the Commonwealth, which is a way that we are beginning to streamline the care that we are giving. In addition to that, this committee set up the Health Policy Commission that is helping us to evaluate where our resources are. The conversation around single payer is particularly around the use of resources and very bluntly, the waste of resources in redundancy, in procedures, in administrative personnel. The work of the Health Policy Commission is helping us to deal with that in a very concrete way. We've also seen a consolidation of the provider networks, and that was much more rapidly than I think any of us had envisioned. But even in that consolidation of the provider networks, we're beginning to see very thoughtful strategies around quality of care and around cost containment. I would make the case that this bill helps us once again to see that lens, but we are doing significant work in the Commonwealth of Massachusetts, and we are moving forward in a thoughtful manner. I want to respond to Rep. Altrino's question because I thought it was very thoughtful and very insightful. There are dangers if we do not do this thoughtfully and deliberately. It is going to take all of us working together to move forward. I believe that healthcare is a right. I am willing to work on that for the people of my district, the people of my Commonwealth, and the people of my country. And I do believe that we can accomplish this in a thoughtful, deliberate manner.
Thank you. Oh, I'm sorry.
I wanted to add quickly, because you had talked about the roadmap to implementation, that there are actually numerous studies that have been conducted for other states. So we've seen studies from California and New York, and quite frankly, in drafting this legislation, the federal study has been quite helpful and has highlighted things that I think Massachusetts is going to need to look at, particularly around how does this impact small businesses. So we do have guidelines, and I personally always look to the Canadian system when I think about how can we implement. Canada, as I'm sure you know, started with one province, and then it moved across. So we do have those ideas. Of course, our state is different, but we do have a GDP similar to that of Norway's, which manages to have single payer on its own. We have other challenges, but I think that the roadmaps are there if we, as Representative Garlick said, work together to look at them thoughtfully.
Great. Just to follow up, so my other question was about out-of-state residents who work in Massachusetts, but then also to follow up with the waiver. So our current waiver is good for another couple years, so we won't be applying for a new waiver for 2 years. And so moving forward with this now would be somewhat problematic because a big option or a big piece of what would need to happen is still 2 years away. And there have been a tightening, not a loosening, of how those funds can be used under the current administration. So that would be also a real unknown out there. In fact, one of the conversations my staff and I have had is trying to think of a way of creating a public option as a way of transitioning. And the monies that come in for Mass Health, Medicaid dollars, really, we're not allowed to even be using them in that way. So there's a lot of federal restriction that we can advocate to change, but we can't change. So I'm curious about your thought process around the likelihood of a waiver, because that would obviously be a critical piece to this, but also how do we deal with out-of-state workers, which a federal Medicare for All system would automatically handle. So, thank you.
Do you want to start?
Yeah, so as far as the waiver, I mean, we're certainly hoping the committee will report out favorably and act to establish Medicare for all and make progress this session. And with respect to the fact that the next waiver is not till 2 years, first of all, that's probably good news. I hope perhaps another person is in the White House in 2 years. And I think it's realistic to say that, you know, we would need a more robust waiver than we currently have. I think we recognize that this is a growing movement, and any advice that the committee has on how robust that waiver should be and what the specific details would certainly be helpful to, you know, the proponents of single payer. With respect to out-of-state employees, you know, certainly it could be an exemption for those that are earning are working here in Massachusetts but live somewhere else, because at the end of the day, we're providing health care as a right for Massachusetts residents and not just for those, you know, not for people who are working here. So that could be an exemption where they're not paying a payroll tax and therefore they're not receiving health care as a right, and they will receive health care in whatever state that they live in. But I personally think those are things that could be worked out by state government and the legislature.
And I would like to add that we are submitting testimony from both of our senators and several of our congresspeople today. So we have a lot of support from our federal delegation. So in terms of making sure that we continue to get that waiver, it's heartening to know that they are behind us.
Sorry, not to harbor on this, but I grew up in New Hampshire and my family all worked in Massachusetts. So this is something that is clearly near and dear to me. But by not allowing people who are working in Massachusetts to get health care, they can't get it in their own home state because their employer would no longer be mandated to supply insurance coverage. So from a moral perspective, I think, you know, we have to be very, very careful about not creating losers in sort of the whole region around us. So I'll just leave it at that.
No, absolutely. And some of the various roadmaps that have come out with different studies have talked about how to handle that, whether you have a provision where that health insurance is accepted out of state, that, you know, obviously people travel with their health insurance, so if Massachusetts has a single payer system, that could be an important thing that we need to cover as well. I mean, obviously New Hampshire, in my area, a lot of people work in Connecticut, so we have that very same issue. But I do think that it requires all of us to really work together to figure out, like you said, that we're not going to have losers in the system, because really the goal is the absolute opposite.
Thank you so much. Thank you for your personal stories. Those are very helpful to share those. I'm curious, your interactions with 3 other countries, I think you said that you were.
I'm so sorry, I can't quite hear you.
You had indicated that you were in three different countries that have health. 4. Okay. Can you talk a little bit more about those experiences, the pros and also the cons of those, of having that as well, if there are any?
I can certainly try. I was in different life experiences in different places. So I lived in China, the United Kingdom, France, and Italy. I received health insurance in China almost automatically. It was very easy, and I was actually there during the SARS epidemic, so it was kind of a fascinating moment to do that. And there weren't any real drawbacks, but I was much younger in life. I actually lived and worked in Italy for a much longer time, so I was paying into the system as well. I mean, of course, the drawback is, you know, that you are paying more, and especially in Italy, the taxes are much higher because they're covering health insurance as well as many, many other benefits that we aren't possibly addressing here today, things like childcare and free higher education. So that definitely felt like a drawback when it came to seeing my paycheck. However, I will tell you that when you can get a doctor to come to your house in the middle of the night when you have food poisoning, that doesn't feel like such a drawback. My partner, I mentioned his family is in Italy. He got sick here and ended up traveling back because we had much better coverage to treat the cancer. I don't really know how else I can describe living in a system where when you need to access care, there are no referrals, right? You need to go to a chiropractor. You don't have to go to your general practitioner first. You can go into pharmacies and actually get the medication you need without going through multiple doctors to get various prescriptions. I mean, the drawback is the hospitals are not as fancy as here, for sure. They're not glittery and sparkly, and there aren't, state-of-the-art services always. I misspoke. There aren't state-of-the-art luxuries almost, but the services are there. The basic services that you need are there, and I would honestly trade that for the system that we have here. Yes.
Thank you, Madam Chairman. How would this, how do you anticipate this would work if somebody, say, were in another state in California or some other state, pick it, had a critical car accident and was laid up and in a hospital in another state for an extended period of time, racking up literally hundreds of thousands of dollars worth of cost? How does this work to protect that Massachusetts resident?
I mean, I would assume the healthcare trust would just, cover the healthcare for that person who's not from Massachusetts, similar to, people that travel to other countries and have a medical emergency or an accident. They go to the hospital and you're certainly not paying taxes to that country, but you get treatment. So I think it's just accepted as part of the system. And all things considered, I wouldn't think it would be a very significant cost, but it would be part of making sure that universal health care is there for, anyone who's in Massachusetts.
Right, so you would anticipate that the providers in another state that have a more traditional insurance setup would bill through their insurance to this trust and get paid from the trust. Is that how it would work?
Well, I honestly don't think there would be a bill. It would just, the person who goes to the hospital would have their health care taken care of. Who knows if they're paying a very small fee at the hospital, and then they go on their way, right? If it's a more serious incident, then the state pays the doctors who take care of that person who's injured. Again, it's a universal system where health insurance companies don't exist.
Well, they do exist in other states, and that's my question, is how do those insurance companies / providers and all of the stuff we know today that exists in another state interface with what this would propose as a single-payer system in Massachusetts?
Mm-hmm. It's certainly, Representative Garlick, yep.
Representative Hunt, if it's helpful to you, there is language in the bill that actually deals with emergency care and treatment of non-residents. The concern about that is that the language of the bill says that any non-resident will receive emergency care, and then the trust will try and recoup those expenses. There's also language in the bill that talks about non-residents and the care that they would receive, in which then they would be billed for services, but we're not clear about what that system would be and how we would bill non-residents for services.
Okay, my question is the opposite. I'm the person who's covered by this system here in Massachusetts, and I go somewhere else on vacation, get critically injured, and am laid up for 2 months in various hospitals and therapy, that type of thing, or at least to the point where I'm able to be transported one way or another back to Massachusetts. How do those other state systems bill for all of those services that are incurred by me in that other state? That's my question.
Yeah, I would suspect that if there's bills, say, out of California, you have an accident in California and there's bills, those bills are sent to the Massachusetts Healthcare Trust since the person is covered by the Massachusetts Healthcare Trust, and then the bills are paid to the provider in California. I mean, we're talking about fairly modest issues here. The real focus is on healthcare needs for Massachusetts residents in Massachusetts. I'm sure there will be some people out of state that have accidents, but I think we probably can acknowledge it's not significant.
One last thing, Madam Chairman, if I could. We do have a lot of people who are Massachusetts residents who are retired, who spend nearly 6 months in other states, in the Sunshine States, who are elderly and require a lot of health care. So does this health care trust then just kick in and pay the gap that's created under Medicare federally for those people? How does that work?
I would imagine that's an accurate scenario. You have to make up the difference.
I just wanted to add that even under our current system, that is still a problem. If I go to California, I mean, that's actually what part of my story was. Not all health insurance is accepted at all hospitals. So if I go to California and they don't accept my health insurance, I'm also in a difficult position. I mean, this would allow the trust to pay, but I mean, that problem is a problem that until we take up healthcare federally, we're going to continue to see persist. And just in terms of traveling overseas, it really does depend on what your current insurance is. You don't know if you're going to be covered. I was lucky to be in countries where I was covered, but that is not true in the entire world.
I just want to ask all the legislators who are standing with us if they could introduce themselves.
Representative Miguel Lugardo, 15 Suffolk.
Representative Mike Conley, Cambridge and Somerville.
Representative Hawkins, Attleboro.
Representative Michelle Socolo, 15th Middlesex, Lexington, and Woburn.
Representative Tommy Vitolo, Brookline, and to my left was Representative Jack Lewis, Framingham?
Yes.
And Senator Jo Comerford, she's a senator, so she probably has 25 different communities.
Franklin, Hampton, Worcester. And then there was also Representative Gouveia. Everybody's running today, so apologies. And Representative Wynn as well.
Great. So not to belabor this, but I think I just wanted to commend the members of the committee who are taking this very seriously. And these are a lot of the questions that we're internally talking about because it's not just about, as I said before, the ideal, which it would be absolutely ideal, but how do we actually get from where we are today to this? And there are so many questions and so much that we still don't really know. And I think that emergency scenario in California could easily be a very, very high cost and put a lot of wear on the trust fund because we wouldn't have negotiated rates. We would be paying list rates. We wouldn't be operating necessarily like a health insurance company that is, contracted. And I would also add that I think, as Representative Garlick mentioned, the success of the ACO model. The ACO model has been actually very successful in mass health, but that means referrals. That means so. We're in disagreement, or we don't know what the system would look like if you never need a referral and never need anything, and you can just go anywhere you want. Is that the best for patients, and is that the best for cost? So I think there's so many questions, and I will end with. We're working on legislation to address access and cost here in Massachusetts, and we're taking that very seriously. And a big piece of that is understanding adequacy. What is adequate for hospital payments? What is adequate for pharmaceutical payments? And these things are very, very hard to pin down, and there's a lot of variation. And so I think it's the complexity is not as simple as the tagline Medicare for all for us. Because if we could expand Medicare, the federal government needs to expand Medicare, period. That is the right solution that could be done easily, so to speak. But we have to create an entirely new system and answer all of those questions on our own. And so I think I just want the public to understand that we take this very seriously. I think we all agree on some level that this is the right way we should be going, but it's getting from here to there is the question. So thank you. Thank you all for coming forward.
And Madam Chair, if I could just offer two final comments, is that, I think the issues you raise about the complexities is because of the healthcare system we have, and so the problem is just playing around the edges is not going to address costs, it's not going to address universal coverage, it's not going to address the deep inequities in the system, and that's why, we're all here to argue for a totally revolutionary system that changes the current system. And if you're just working around the edges, you're not going to address prescription drug costs, you're not going to address rising deductibles, you're not going to address rising costs for employers. My second point is that, sort of related to the emergency, is recognize there are Massachusetts residents here who have healthcare emergencies and have to file for bankruptcy, okay? So put aside the California example. There are Massachusetts residents here that are having healthcare accidents, tragedies, and are paying hundreds of thousands of dollars out of pocket or filing bankruptcy. That is outrageous, and we need to fix it. Thank you again for hearing us out of turn. Appreciate it.
Yeah, thank you. Thank you for your testimony, and I want to I understand. And I just want to echo what my chair said, that co-chair said, is that we are taking this very seriously. I think one thing I would like to see, and I think it's to, I can't remember whose question it was, but there are going to be changes if we do this, big changes for people. I would maintain that today we absolutely ration health care because we ration it based on whether you can pay or not. But Medicare, very transparently, is very clear about what they will cover and what they will not cover. And people need to understand that when we go to a system like Medicare, we're making those decisions. They may be great decisions, they may be the right decisions, but they are decisions that people are going to make. As somebody on Medicare, again, I have access to great health care, and there are things that Medicare says, no, we won't cover that. So I just don't want to set up this ideal that if we go to a Medicare for all, we go to single payer, that all of a sudden everybody is going to have access to every single thing they need when they want it, if they want it. And I think part of what we have to do in order to get to this, to a single payer system, is to bring the public along with us. And the only way we could do that is to be really transparent, be really clear about what this is going to mean, what it's going to look like to them, what it's going to cost, and what the trade-offs are. And I absolutely agree, this is a broken system. I can't defend any of this. But we are, when we make those changes, we will be unsuccessful if we can't bring the public along with us. And in order to do that, we have to have the answers to all of these questions so that we can be honest and there's a trust there. So I just thank you for all of your comments and your questions. I really appreciate it, and thank you for coming.
Great.